Good evening, everyone. A very warm welcome to all of you joining us today for the World Asthma Day webinar 2026, organized by the Spice Route Young Doctors Movement South Asia region. Before we begin the scientific program, it's my pleasure to invite Dr. Vishnu Bina Satish, Regional Chair of the Spice Route South Asia, to deliver a brief welcome address.
Thank you, Dr. Manoj, for that introduction. So today we are celebrating the World Asthma Day 2026, and the team Spice Route Sri Lanka has come up with a very innovative session for the next 1.5 hours on the clinical updates on asthma, the early diagnosis and management, how we are going to tackle in South Asia in a resource-limited setting, where we as primary care physicians are the primary person who is capable of managing asthma at a primary care level. So we have 5 speakers lined up for today to deliver an excellent discussion on the common topics that we encounter. And I would like to invite all the 5 speakers and Dr. Manoj to be the moderator for the day. Over to you, Dr. Manoj.
Thank you, Dr. Vishnu. So today's session focuses on clinical updates on asthma, especially early diagnosis and management in South Asian region. So asthma remains significantly underdiagnosed and suboptimally controlled in our region. And this session is designed to share practical real-world approaches that we can directly apply in our day-to-day practice. We have an excellent panel of speakers with strong academic and clinical backgrounds, bringing diverse perspectives from across the region. Please feel free to post your questions in the chat during the session, and we'll take them up during Q&A at the end. We will also aim to keep strictly to time, allow space for discussion. So, our first session is underdiagnosis and missing cases of asthma. Our first speaker, Dr. Sashanka Rajapaksha, brings a unique blend of clinical medicine and research with training in nanoscience, respiratory physiology, and AI and biostatistics, and he is currently pursuing his PhD. He is unable to join us live today, but he has kindly shared a recorded presentation. So let's begin with his talk.
Welcome. I'm Dr. Shashanka Rajapaksha. This is a brief 10-minute talk on the prevalence and underdiagnosis of asthma in rural Sri Lanka, drawn mainly from 2 of my published studies. Asthma is the most common chronic disease in childhood, with the current VS prevalence ranging from 29 to 32% based on ISAC studies, and the highest severe asthma burden is in lower middle income countries. In South Asia, the data show an apparent paradox. Symptom prevalence is high, but recorded diagnoses are low. This is not because asthma is truly rare, it is because most cases go undiagnosed. As family doctors, you are the primary point of contact for children with recurrent cough and wheeze. It is the critical window for an early diagnosis. Undiagnosed asthma could lead to uncontrolled symptoms, preventable emergency presentations, and significant school absenteeism. These studies come from Anuradhapura, a typical rural district, so the findings are directly applicable to primary care settings across Sri Lanka as well as South Asia. The first study I would like to discuss with you was conducted to assess the epidemiology of wheeze in preschool children. We recruited 1,060 preschool children from 36 preschools distributed throughout Anuradhapura district, and we used the ISAC methodology for reproducibility. The most critical finding was that despite 7.2% of the participants having severe wheeze, only 35.5% of those children had ever been diagnosed, despite presenting to healthcare repeatedly with severe and recurrent symptoms. This is the diagnostic gap that we need to close, not only in Sri Lanka, but also in the South Asia. The risk factors identified for severe wheeze with multivariate logistic regression addressing for potential confounders. were allergic rhinitis, domestic dogs, exposure to passive smoking, and the protective factor was having a cemented floor. Allergic rhinitis is the most powerful predictor with an adjusted odds ratio of 6.9. This is the key morbidity to identify and treat. Cement flooring is a modifiable environmental protective factor. The clinical relevance is that in children with allergic rhinitis or in children with severe wheeze, the doctors, especially the primary care physicians, should investigate and screen these children for asthma. The previous study raises a question. Was the prevalence of physician-diagnosed asthma low only because the children were younger? The physicians are hesitant to label asthma at that young age. Therefore, we conducted another study, this time recruiting 1,029 adolescents from 6 secondary schools located in the Anuradhapura Municipal Council area. We used both the ISAC and the asthma control test. We found that the physician diagnosed asthma prevalence was 19% and the severe asthma prevalence was 15.3%. The most important finding of this study with relevant to family care is that 29.9% of the children with severe asthma had poor symptom control. That means, despite being under medical care, due to either inadequate treatment or inadequate symptom control, inadequate measures taken to mitigate exposure to exacerbating factors, inadequate education, or a wide variety of reasons. These children's asthma was not adequately controlled. The independent risk factors for severe asthma in these adolescent children discovered a unique factor that is tied to the economy and the social situation of their households. Sleeping on the floor using a cloth without adequate bedding was a significant risk factor. This increases the exposure to allergens and exposure to dust, probably leading to increased risk of exacerbation. Also using sodas for cooking fuel and concurrent eczema and allergic rhinitis. And the preventive factor was again having a cement floor. This was observed also in the preschool children. Therefore, for your practice as family care physicians, it is important to ask about allergic rhinitis in children presenting with wheeze or asthma and treat both together, as well as screen for eczema. The atopic triad is the key risk cluster identified in these two studies, and the cooking fuel should be explicitly questioned from the parents and advised on a less damaging method, as well as you should pay attention to their bedding and the social situation and advise them appropriately. Although this is not a prospective cohort study with longitudinal follow-up, these two cross-sectional studies conducted in rural Sri Lanka shows an important message. If you look at the current wheeze, the numbers are almost identical, and the severe wheeze has doubled in the adolescent age group. This highlights a gap in diagnostics as well as in therapeutics. The physician diagnosed asthma prevalence has increased in the adolescents. However, we noted earlier that the symptom control is poor in almost one-third of those participants. The diagnostic gap remains, as well as the risk factors pertaining to the atopic triad and the domestic conditions should be questioned and addressed as appropriately in your care. The protective factor of cement flooring is important, showing that in these households, with advice and social support, we could improve the condition for these children. I would like to end my presentation with 4 key messages for you. Number 1 in 4 children have current wheeze, whether it's preschoolers or adolescents. The second is that most of the severe cases are undiagnosed. And those who are diagnosed are still suffering from poor symptom control. And we should also treat the nose as well as the lungs. The nose, the lung, and even the skin go together in the atopic triad. And very importantly, ask about the domestic environment and the exposure to potential exacerbating factors. And the two papers that I presented today are available free of charge and open access. And I am happy to share any information that you may require if you contact me. Thank you very much for your time, and it has been wonderful talking to you.
Thank you, Dr. Shashanka, for that insightful presentation, highlighting the importance of important issue of missed asthma diagnosis. Next, we move to asthma in vulnerable populations. Joining us is Dr. Sweta K, a family medicine specialist trained at CMC Vellore, currently working as a senior resident with valuable experience in managing high-risk and vulnerable groups. Dr. Sweta, over to you. Dr. Sweta, we can't hear you.
Hello, can you hear me now?
Yeah.
Yeah, shall I start? Yeah, give me 1 second. Is my presentation visible?
Not yet. Previously it was visible.
Yes. Is my presentation visible?
Yeah.
Yeah. Thank you for the opportunity, Spice Route Sri Lanka, for providing me to talk about asthma. So, asthma in vulnerable population, I would like to include older age group as one of the vulnerable population because of as asthma is mainly talked upon as a younger age group disease. So, asthma is not just an younger person's disease. There is a late onset asthma which can start in adulthood or even in old age. But what are the problems in asthma in an older age group is that, which I will also like to call as geriatric asthma, is that elderly will lose the reversibility of airway obstruction. So, classical spirometry may not yield classic features of asthma, and also age-related physical impairment can delay diagnosis. And most importantly, our majority of our asthma clinical trials, inhaled corticosteroids and other inhalers, have excluded older age group. So we may not know about the drug interactions that these inhalers can cause in older age group. And we also know that the multimorbidity and polypharmacy complicating the situation. And there is a little reliable data on incidence in this age group. So many of us fail to use spirometry as an important tool in diagnosing asthma in elderly. But studies have shown that nearly 90% of the motivated elderly people can complete the spirometry. So spirometry has to be extensively used in diagnosing asthma, regardless of its pitfalls. And there can be age-related airway changes in the elderly, which can be named as a senile lung. So that can be mistaken for an irreversible lung disease, whereas the patients may just have an age-related disease superimposed with asthma. And there is commonly asthma COPD overlap. So elderly asthmatics, probably even long-term asthmatics who are poorly managed because of there were no inhalers in the past, right? So they may mimic COPD. So in those patients, DLCO can be a useful indicator, which is normal in asthma, but it is reduced in case of COPD. And there is something called as immunosenescence. As my previous presenter rightly pointed out, atopy is an important feature of asthma, whereas in elderly, atopy may diminish with age because of something called as immunosenescence. So we are stuck on all directions in diagnosing asthma. So as we have already discussed, DLCO is an important tool, can be used if there is no reversibility in spirometry in patients suspected to be having asthma in elderly. And presence of a longer disease duration which has started before 40 years of age also points towards asthma. So let's come to the management of asthma in elderly. So what are the common blocks in managing asthma in elderly? That is called as polypharmacy. That is beta blockers, which are commonly prescribed for elderly, probably due to heart failure. They cause bronchoconstriction. Calcium channel blockers, itraconazole and clarithromycin can increase the inhaled corticosteroid bioavailability, thereby worsening the drug interactions. There is also a risk of HPA axis suppression, probably due to the inhaled corticosteroid and also due to the oral steroids, which can be used more frequently in recurrent exacerbations in asthma in older age groups. And also device technique. Due to arthritis, tremor, cognitive impairment, device technique may be difficult, in which case spacers and synchro breathe, the breath activated devices, actually help in managing asthma in elderly. And even physiology is not in our favor because beta-2 receptors number and affinity is reduced in older age group, and the drug clearance is very slower in hepatic and drug clearance is slower in older age group, and cardiovascular comorbidity has to be considered before giving a beta agonist. So the common side effects of corticosteroids can occur in elderly with just the inhaled corticosteroids, which is not common in an adolescent younger age groups, but which can commonly occur in an older age group. Those have to be kept into consideration. In which case, there's an option of using beclomethasone, which can actually surpass the first pass metabolism and which can actually reduce the inhaled corticosteroid systemic side effects. So what to use as a reliever therapy? We commonly use a beta-2 agonist and an ICS, but is beta-2 agonist really safe? Probably not, because beta-2 agonist will cause hypokalemia, QT prolongation, tachycardia, and tremors, which can worsen our current management. But anticholinergics will cause dry mouth, urinary hesitancy, glaucoma exacerbation, mild cognitive impairment. So we have to choose between the two. Both of them can be a double-edged sword, in which family physician is going to play a bigger role, because we are going to individualize our treatment based on their other comorbidities. So what about the oral options? Theophylline is very risky because of slower metabolism, because of older age group. Montelukast can be used, better adherence is there than inhalers, but the neuropsychiatric complications has to be taken into consideration. Omalizumab can be used, but it is not in a primary care level. They have to be referred to a pulmonologist. So other problem that we have is they may also have shared risk factors like allergic rhinitis. GERD can be worse in elderly. Depression, anxiety, cognitive impairment is going to prevent asthma medication adherence. And also our complication related due to ICS and beta agonists has to be considered. So beyond the asthma in older age group, I would like to focus more on the vulnerable populations apart from the old age. So asthma care is not only due to biology or age. It is this varies mainly based on where you live, what you earn, and who treats you. This is a graph provided by the USA, where racial and ethnic identity is going to change the way about your asthma care. But in Southeast Asia, our more common problems related to asthma care are there is common air pollution and biomass exposure and health literacy gaps. Inhaler technique and self-management plans are uncommon outside tertiary care. And also, specialist care is more mainly focused in the urban areas, whereas the rural, semi-rural, tribal areas are left with minimal resources, minimal testing, and medications. And also, even in urban areas, overcrowding and dampness, mold, dust mite, cockroach allergens is going to flourish, which can worsen asthma. And inhalers are not readily available as a government service, so out-of-pocket cost is going to tremendously increase. And because of various myths and beliefs about MDAs and inhalers, such as that MDA will cause addiction. You'll be addicted to an MDA once you start using it. Sounds crazy, but it is common in my own clinic population. So many of them go to a yoga, herbal, traditional methods, Ayurveda, Siddha medicines. So what can we do in tribal and indigenous communities? Is asthma really common? Yes, because of their remote geography. They are probably either much remote in the forest or in the hilly areas. Cold air exposure, biomass exposure is going to worsen or increase the prevalence of asthma. And common occupation is agriculture. So occupational asthma is going to play a major role, which needs to be addressed as a family physician. And there is obviously language barriers in tribal areas. When we don't know the language, we may never be able to teach the technique of an inhaler or technique of a spirometer properly. And as there are no resources available, obviously the local quacks, local healers are going to take role. That is going to complicate the current illness or even prevent them from seeking the appropriate asthma care. And they're not commonly studied in our routine epidemiological studies. So that is also going to be a major gap. And is caste is a structural barrier? Yes. People belonging to lower socioeconomic caste may perform manual labor, domestic workers, sanitation, garbage cleaning, construction workers. So they are more prone to occupational asthma than a normal population. And also they have poor resources, medication access. So diagnostics is going to take a longer time, and also intersectionality with gender has to be taken care of. Lower caste women is going to suffer more than a lower caste man. And also there needs to be more advocacy for people who are from a low socioeconomic background, especially working in industries and other high risk areas for asthma. So I've talked so much about socioeconomic status affecting asthma, and about tribals population being vulnerable population, unable to access asthma care. And also socioeconomic status is going to catastrophically prevent you from getting the appropriate asthma diagnosis, investigations, and treatment. So, but is it really going to be not impossible? No, never. So that is where I'm going to tell you an example of what happens in a remote tribal village in Tamil Nadu. These are the photos taken from the Kesipatti Primary Health Center, which is from the lower Kodaikanal Hills, manned by Dr. Rajkumar Ramasamy, brilliant family physician who is my mentor. So these two are two health workers. They are from the same community as the tribal village is. So they are going to talk in a language which the patient and the attendant are going to easily going to understand. So there's a health worker demonstrating to a patient about how to use a peak flow meter, and also how to use an MDI. I do also have a video. I hope there is some time. Is it? This is my last few slides. It is in Tamil, so
நல்லா குலுக்கிட்டு இது அந்த ஸ்பேசரில் ஒரு சைடு வாயில் வைக்கிற மாதிரி ஒரு சைடு மாட்டுற மாதிரி இருக்கும். அதை மாட்டிட்டு இந்த சைடு வாயில் வச்சுட்டு ப்ரெஸ் பண்ணணும். ப்ரெஸ் பண்ணிவிட்டு உங்களால் எவ்வளோ தம் கட்டி இருக்க முடியுமோ இருக்கணும். மெதுவாக இழுக்கணும். அது வரைக்கும் இது வாயில் வந்து வெளியில் எடுக்கக்கூடாது. நீங்கள் செய்யுங்க பார்க்கலாம். சொல்லிட்டே செய்யுங்க.
ஃபஸ்ட்டு இது நல்லா குளுக்கணும். மருந்தும் தண்ணியும் ஒன்றா கலக்கணும். அதுக்காக இது நல்லா குளுக்க வேண்டியது இருக்குது. அப்புறமா நம்ம நுரையில் இருக்கிற காற்றை கொஞ்சம் வெளியில் ஊடணும். ஊதியாது. அப்புறம் இந்த பேசரில் இதை இப்படி சரியாக பொருத்தணும். பொருத்திட்டு இதை வந்து ப்ரெஸ் பண்ணிவிட்டு நல்லா இழுக்கணும்.
So, this is how they demonstrate. So they have a sample spacer and for them to demonstrate. And these are people from the same community. So it is going to be very easy for people in these tribal areas from the lower Kodaikanal hills who seek care for asthma to get the hospital treatment that they want. So what can be done for asthma in the vulnerable population? First thing is decentralized asthma care. Bring all the information about asthma diagnosis, investigations, management to everyone, from yourself to your nurses, to your health workers, to your drivers, to your community health volunteers, to everyone. Everyone is going to be an health advocate for not just asthma, it applies for every disease, but here, especially for asthma. And also about follow-up and continuous MDA technique, MDA usage. And there are high-risk groups in asthma. Since there is a resource limitation, we need to consider to prioritize our resources in giving vaccinations. So severe asthma on oral steroids, old age, or recurrent exacerbations, and remote difficulty to access areas with people living with asthma can be given priority. And financial support for MDA, that is the most important thing, which is going to be a major challenge in getting asthma management. Currently, the government's schemes in India and Tamil Nadu has improved so much that they'll be able to get inhalers from somewhere nearby or even somewhere far at a very nominal cost. As family physicians, it is our responsibility to advocate for proper asthma care in the near future. And also environmental remediation. We family physicians are the best in doing that. We know the patient in and out. We know their patients' homes. So we can individually visit their homes, find out what is causing the exacerbation, help them manage it, help them prevent it. And also health education about asthma to everyone. And as I've already told, we can give individualized care based upon every patient's preference and capability to use MDIs and use inhalers. And we family physicians are the really best in individualizing care to every individual patient. Not pulmonologists, not general medicine people, but we family physicians are the best in giving individualized care. So peak flow meters in remote settings are used for diagnosis. Pulmonologists may laugh at it, I can't help it, but peak flow meters in remote areas where there is no spirometry available are used for diagnosis. They do peak flow meter in my mentor's clinic. They do peak flow meter at every visit. Whenever a COPD patient comes to visit to get inhalers, they document a peak flow meter recording. That is going to be really useful in understanding when they are going to have an exacerbation. And also, it also knows us what is their normal FVC during the in a normal time when they are not having any exacerbation. And also, we use a peak flow meter before in nebulization and after nebulization, and we can see reversibility like that. In hopeless situations, that is the only tool that we have. And also decentralized healthcare, where there are no doctors and respiratory technicians are not available. Handheld spirometers and peak flow meter are going to be necessary diagnostic tools for asthma. And the healthcare team is going to be the asthma respiratory technician. And also communication gap, as I've already told, demonstration by the same healthcare workers from the same community is going to reduce communication gap to massive amounts, and also will address to their own health concerns in their own language, which is going to be a bigger boost. So bring your asthma care to your community, and we as family physicians are responsible to do that. We are capable of doing that. So I think, and so just a small summary. So elderly with cough, think about asthma. Regarding management, think about inhaled corticosteroid side effects, and also look at various comorbidities in elderly while you're treating asthma. And in case of asthma in elderly, use DLCO. So look at every prescription for asthma in elderly, and also see about the individual and contextual factors in managing asthma. So thank you. I've finished my presentation.
Thank you, Dr. Sweta, for that very practical and relevant discussion. Our next section is practical staging and assessment in resource-limited settings. We are pleased to have Dr. Maitri Rupasinghe, a specialist in family medicine and a fellow of both College of General Practitioners of Sri Lanka and the Royal College of General Practitioners, with extensive experience in primary care. Dr. Maitri Rupasinghe, over to you.
Manoj, can you see my slides?
Yes, sir.
All right, wonderful. So,
It's not in the full screen, sir.
yeah, I'll put it in the full screen. Okay, okay. So, thanks for this question for just letting me speak to you on this important topic. So, good evening to all of you. Today, I'll be talking about the practical staging and assessment of asthma in resource-poor primary care settings. The key message I want you to remember from the start is this: asthma assessment is to require advanced technology to be effective. Without even spirometry available, good asthma is possible using simple structured medical tools in resource-poor settings. Over the next 10 minutes, I'll show you how. This topic matters enormously in South Asia. As you all know, asthma prevalence
Sir,
is
your
high.
voice is not clear.
So, yeah, just let me just wait a while. Can you hear now? Hello?
We can hear, sir, but not clear.
Yeah, give me 1 minute. I just joined with give me 1 minute. I'll join with can you hear me now? Hello?
We can hear, sir.
Hello, can you hear me now?
Yes, sir. Now it's clear.
All right, sorry about that. There was a problem with the speaker. So now, yes. Yeah. So let's start again. Okay. So now what I was talking about was the topic matters enormously in Southeast Asia because asthma prevalence is high, yet many patients remain undiagnosed or diagnosed late. Most of these patients are not seen by specialists to start with. They are managed in primary care often by very busy primary care clinicians. So common challenges we have include the lack of spirometry and short consultation times, cost constraints for patients, and limited access to investigations and follow-up. Uh, because of these barriers, asthma assessment can feel frustrating or incomplete. But instead of seeing these limitations as obstacles, we need workable, realistic assessment methods that fit our settings. That's the transition today, shifting from ideal technology heavy approaches to practical, clinic ready strategies. Yes. So when we talk about practical asthma staging, we are not talking about complex lung function testing. This approach is control-based, designed specifically for primary care. It focuses on two things. One is current symptom control. Second is future risk, especially risk of exacerbations. So importantly, it does not depend on spirometry and is strongly supported by modern guidelines such as GINA. The entire assessment is built around simple clinical questions that can be asked in just a few minutes. The key point here is practical staging is based on symptoms which you can obtain by simple data gathering and simple tools, not expensive investigations. So it's important for you to understand this phenomenon where, at every asthma visit, whether new or follow-up, there are five core clinical elements we should assess. Now, these are daytime symptoms, which includes wheeze, cough, breathlessness, and chest tightness, and also nighttime awakening due to asthma, and also how often the patient uses reliever inhaler, and also activity limitation at workplace or school or exercise for children for school and exercise and even adults. And recent exacerbations or need for oral steroids is another thing that we look into. So based on these answers, we can easily classify asthma as well controlled, partly controlled, or uncontrolled. This classification guides treatment decisions and follow-up intensity. The important thing is consistency, asking the same core question at every visit, not changing the tool when a patient is assessed the next time. In busy clinics, symptom scores can really help, like say simple validator tools like GINA symptom control questions, the asthma control test. When feasible, you can use either as a a soft copy or as a paper-based thing. These tools can be used verbally on paper, as I said, or even informally, and they do not require high literacy, as shown by the previous speaker, if administered by the clinician. So why are they useful? Because these symptom scores improve consistency, reduce subjective bias, and help track changes over time. So the clinical pearl here is even when you think you know the patient well, sometimes we think that the patient is under good control just casually. The symptom scores often reveal poor control that was underestimated. So this is the objective assessment with the tool helps a lot to assess the patient fully in asthma. Now this is the GINA assessment of symptom control tool. Uh, which assesses asthma symptom control over the past 4 weeks using four key questions. It simply asks about daytime symptoms occurring more than twice per week, any nighttime awakening, reliever use more than twice a week, and any activity limitation. Based on these, the number of yes responses, asthma control is classified into three levels. If none of these features are present, the asthma is considered well controlled. If one or two are present, it is partly controlled. And if three to four are present, the asthma is classified as controlled. Now, here is the asthma control test, which assesses how well asthma has been managed over the past 4 weeks. It includes five questions about daily activities, shortness of breath, nighttime symptoms, use of rescue inhalers, and overall control. Each scored from 1 to 5. The total score helps, as shown here, helps determine whether the asthma is poorly controlled or well controlled, guiding patient and the doctor in taking treatment decisions. With that, let's move to the peak flow meters. Peak flow meters are sometimes, as the previous speaker told, are dismissed by specialists but in low resource settings, they remain extremely valuable. As you all know, they are low cost and portable and reusable and easy to teach, and also it doesn't need high technology and even electricity, right? So peak flow helps, especially in diagnostic uncertainty, as you all know, and to monitor trends of patients and also patients who poorly perceive symptoms. Sometimes, we find these patients in primary care settings where the patients do not believe that they have asthma. So it's important for you to understand that peak flow does not replace clinical assessment, and it is a complement. When spirometry is unavailable, peak flow provides an objective anchor to our clinical judgment. So it's very useful in resource poor settings like ours. Now, this study, although not done in Southeast Asia, which was done in 2026 in primary care setting, evaluated the usefulness of peak flow meters in detecting airflow limitation in patients with suspected asthma. It found that peak flow measurements had a high sensitivity of 82%, making it a useful screening tool in primary care setting. This study highlighted that peak flow meters are particularly valuable where spirometry is not readily available, especially in low resource environments. However, the specificity was relatively low, including that peak flow should not be used as a standalone diagnostic test. So overall, the study revealed that it concluded that the peak flow meter is a practical and accessible and complementary tool for asthma assessment, but must be combined with clinical evaluation and other objectives as well. So it's a very valuable tool in resource poor setting. Peak flow interpretation should be kept simple, and you should not, make it complex. The most important concept is the patient's personal best, not the population predicted value. So we should focus on trends, not the single reading. A practical guide you can use is more than 80% of personal best is considered as good control, and 50 to 79% you should be, cautious and should be considering partial control. And if it is less than 50%, it's urgent and you need to act quickly. The key message here is peak flow is most powerful when measured serially and consistently, not occasionally. So, as you all know, asthma is a dynamic disease. So, assessment cannot be a one-time activity. It must be repeated at follow-up visits. At every follow-up, we should review symptoms and reliever use, any exacerbations since the last visit, inhaler technique, adherence and practical barriers, even simple paper-based records to make sure that you give continuity of care is very important when it comes to asthma care. What matters is not the sophistication of the tool, but regular structured review. So you don't. Most of us may not be having electronic medical records, but you may use a simple paper-based medical record to start with. So what genuinely works in real world primary care when it comes to Southeast Asia? So the practical strategies include symptom based assessment at every visit, selective use of peak flow meters, simple verbal or written asthma action plans, patient education built into routine consultations. So these interventions are, as you all know, realistic and they work. And studies and experience show they lead to fewer exacerbations, reduce emergency visits, better long-term control. So this is achievable, definitely achievable. To close, here are the key take-home messages for primary clinicians in South Asia. As you all know, spirometry is very helpful but not freely available in primary care in Southeast Asia. Symptoms remain the powerful clinical indicator, and peak flow meters add value when used correctly. Simple, consistent assessment improves outcomes. Primary care, as you all know, is the cornerstone of asthma control. And my final line for today is good asthma care is possible everywhere, even with limited resources. Thank you.
Thank you, sir, for that clear and practical approach. Next is inhaler technique and adherence challenges in South Asia. We are honored to have Dr. Niranjan Disanayaka, a consultant pulmonologist with extensive specialist training and international fellowships from Royal Colleges in London and the USA. Dr. Niranjan Disanayaka, sir, over to you.
Good evening, everyone, and thank you very much for the opportunity given to me. Um, so it's a very interesting topic, and unfortunately, more than 1,000 people die per day due to asthma. And unfortunately, most of the people who are dying with asthma are from the countries which we represent, that is the low and middle income countries. So is there anything that we can do for it? Certainly. And this is actually one such CME that will help us, and it will make change on the way we look at asthma. So let me just play this for you at the first stage. I hope that you can hear.
We can't hear, sir.
Yes, I think you got the message. And now you can look at this. Okay. And this. And now I think that there are people who can't understand Sinhalese. So what it does say is that the reason that a person is not taking the dry powder capsule is that, rather than inhaling, he finds it easy to drink it. So now when we look at these, basically, I think there is definitely a smile in our faces, isn't it? Right. But, and at the same time, we would feel a little bit, guilty as well, because we probably are responsible for the mistakes of the first lady, the second and third gentleman, and at the perception of the fourth gentleman, because we probably not have done our duty properly. Now, inhalers are complex devices, but it is a very effective device if it used properly. So it is probably our responsibility to make the inhaler simple, effective, and friendly to the patient. So we'll see how we can go through this, especially in the primary care setting, and we see on a daily basis the mistakes that we make. Right? So why do we need proper inhaler techniques? We know that inhaler is a unique device, and it is not like taking a tablet. And at the same time, it is a very important device because it gives the main treatment of asthma, that is inhaled corticosteroids. We know that asthma is an inflammatory disease, and majority of it is responsive for inhaled corticosteroids and corticosteroids for that matter. And it is the only way that we can give the corticosteroid which is needed, where it is needed most, that is the bronchi, and causing minimum effects, systemic effects, which we have many. So poor inhaler techniques will obviously will cause suboptimal disease control, and the patient will have frequent exacerbations. They will have higher hospital rates for that matter, and then obviously increased healthcare burden. And the patient perspective, the patient will have a reduced quality of life at the same time. But at the same time, when we look at it, people will lose faith on us. And I heard a very good, eloquent lecture or talk by Dr. Sweta from India saying that most of our people goes to other types of treatment options rather than taking a properly effective treatment. And probably this is one reason, because the patient we prescribe an inhaler is not taking it properly. And then when the patient doesn't improve, then probably he might seek other avenues of treatment, harming himself as well as sometimes harming the economy of the patient as well. So probably at the end of this talk, we will be able to choose a suitable inhaler to the patient in front of us, not a theoretical patient, but for the patient in front of us, considering his age, his affordability, as well as his comorbidities and disabilities at the same time, and at the same time about the perceptions that the patient has. So choosing an inhaler is not a simple thing. It is just not whether the patient can take the inhaler or not, but at the same time, you have to look at the patient's perspectives as well as whether this patient, can afford that inhaler and whether this patient will be benefited with this inhaler. And we will try to understand the rationale behind each step so that actually, even in our setting in the Southeast Asian region, we have high literacy rate in certain areas. And most of our patients, even though they don't have a degree, they would have studied up to second grade, they have a very good knowledge and understanding. So if we tell them why the understanding, or if we tell them the basically the underlying reason for each step, they will definitely do it better. And then obviously we have to do the correct techniques and identify and correct the common mistakes as well. So when we take an inhaler, 80, whether we like it or not. Meter dose inhaler without a spacer or a dry powder inhaler, probably 20%, 10 to 20% will reach the lung, and out of which maybe about 15% will reach the bronchi. But if you use a spacer with a metered dose inhaler, you might increase it up to 30%, but majority of it will be going through the gut, and most of it will be actually will have a first pass effect, and the systemic circulation, the drug that is affecting the systemic circulation, reaching the systemic circulation, will be most of the time minimum. But at the same time, even though it might be a minimum drug dose that the patient will have systemically absorbed, we have to reduce the dose as much as possible, the most effective dose to the most effective dose. So when we look at the particle size, just for the completion's of sake, so the meter's dose inhaler produce a particle for about 1 to 5 microns, and the dry powder inhaler 2 to 5 microns. And if you look at the left side of this graph, it is the ideal ideal size of that particle that will reach the bronchi, which is the needed site for the deposition of the particle. If the particle size is more than 5 microns, it will usually deposits in the nose as well as in the oropharynx. Or if it is less than 1 micron, it will usually go up to the alveolar level, at which there will be no use of this particle going there. So usually the particle size matters as well, and most of the MDIs and DPI will provide that particle size. Right. So when we look at inhaler devices, so the next important thing is what are the inhaler devices? We have what we call the pressurized metered dose inhaler, where it gives a certain dose in a pressurized way. And some people use the pressurized metered dose inhaler without a spacer, but some people will use it with a spacer. But as I told you previously, using a spacer is most useful, specifically in the elderly group as well as the very young group, so that it will increase the drug delivery, and at the same time, it will increase the coordination as well as it it will reduce the side effects of having a sore throat, because the drug might just go and stuck in your throat. The mask, even though it is there in most inhalers, I don't advise it to use unless it is, if it is a child less than 3 years, maybe the pediatric group, we can use the mask, because when you use the mask, the patients try to breathe from the nose. And we know that in the nose, some of these particles might be, drained out, so that the effective drug going into the lung might be reduced. But in certain instances, we can use the mask, but not always. The dry powder inhalers, basically, we can have the single capsule dry powder inhaler, which we are used to, which we use there are various devices. There's a flow haler, there's a slick haler, there was a revolizer. So in Sri Lanka, there are a lot of types of single dose capsule dry powder inhaler devices, which we put the dry powder in and then inhale. And then there was the multi-dose reservoir dry powder inhalers, where you can have preloaded drugs in a simple device, and then you just turn it or accentuate it, and then take the drug without any problem. And that is in Sri Lanka, we have the turbo haler. I will not tell you the brand names because it is not ethical, but the turbo haler is a cylindrical type haler with a red bottom, where you can just turn it and then just take a deep breath in, so that the drug will be delivered without any issue. And then you have a nebulizer. So in certain instances, we might have to use nebulizer, especially in acute settings. And then we have the breath accentuated devices, where now this is a very beautiful device where the patient's breath will accentuate the release of the drug. And then after that, the drug will be delivered. There were some breath accentuated device in Sri Lanka for salmeterol fluticasone about 10 years back, but it is not available at the moment as far as I know. So there are certain devices that have been there to deliver the drugs. Each device will have its own unique advantages and disadvantages, and some devices might be, we might prefer to certain groups of people, and other device to a certain group of people. But the most important thing when we are prescribing, I think the most important thing is to prescribe a single type of device for drugs. So sometimes you have the reliever as well as a controller, for example, salbutamol with beclomethasone. So if we give a salbutamol as a meter dose inhaler and the beclomethasone as a dry powder inhaler, the patient will be confused, and they will not know how to use, and it is too complicated. And I have seen this happening not in asthma, but in COPD. When tiotropium is there, sometimes dry powder tiotropium is given with the meter dose inhaler for a salmeterol fluticasone. So sometimes combination of inhalers should be avoided as much as possible. But when we use an inhaler, we should know what are the devices that are available, right? So these are the lung depositions that I told you about previously. And in any inhaler use, one of the most important steps don't change actually much. And these steps are very important to understand with the underlying cause for why we usually have these devices on. So having a good oral hygiene is very important. I think in Sri Lanka as well as India, in other South Asian regions, there are a lot of betel chewing, and even in males and females. And sometimes the oral hygiene is really, really poor. Sometimes there are a lot of issues in the oral cavity. And ideally, the patient should have a very good oral hygiene. He should wash her mouth or his mouth before taking the inhaler, so that they will have a pleasant taste. And the other thing is, you have to inspect the mouth piece, and at the same time, so the mouthpiece should not have any dust, debris, or foreign body inside this mouthpiece, so that it will deliver a very clear flow. What I usually advise my patients to take the inhaler is to just before, just after waking, just before before the patient brushes his or her teeth. So there are two advantages of this. One thing, after you wake up, you get your bed tea, have a wash of your throat, and then when you take an inhaler and then you brush your teeth, so you are mixing a regular pattern of things the thing that you regularly do. You usually brush your teeth in the morning as well as in the evening, usually. So if you attach it to the inhaler use, then the tendency to forget they're taking the inhaler probably reduces. And we usually do it in ourselves as well. So taking a drug at a specific time after a specific thing. And at the same time, after you take the inhaler, when you brush your teeth and gargle it out, if you're taking a steroid inhaler, usually the risk of having throat irritation will be less. Preparation of the device is the next one. I will talk to you about later. Each device, the preparation is different, and upright posture with a head slightly back. So when you bend it like this, the airway is narrowed and blocked, and there will be the drug will not actually, whether you are using MDI or a dry powder inhaler, the drug will not flow clearly. So the important thing is not to, uh, raise your head like this, but at a certain extent, erect, and so that the airway will be nicely open and clean, and it will not be obstructed. So that is a very important step. Oral hygiene, preparing the device, having a good posture, whatever the inhaler type you are using. And the next important thing is we have to take this inhaler and allow it to deposit in the bronchi. So you have to have the maximum amount of air through the inhaler device so that we will be able to take the maximum amount of drug in. So the best thing is not to take the tidal breath. There is a method of tidal inhaler use in PMDI and spacer, but especially in a dry powder as well as a spacer with MDI or MDI alone, the most important thing is to exhale completely out, and you will go into the expiratory reserve volume, and then you take a breath with the inhaler. The way you take the breath through to the inhaler is different, especially depending on the type of inhaler you are using. So if you are using a dry powder inhaler, the way you may take the breath will be fast, because you have to get that drug out of the capsule and to your lungs. So it will be a fast and a single fast breath, right? But if you are taking to the inhaler through a spacer, it should be not a very slow, but it should be a very slow and a sustained inhalation, like that, right? A dry powder on a capsule, wrap it in, and then through the spacer, you take it, right? And then if we just put it out, right, you know that in the airways, the drug is there, and the drug should have some time to deposit in the bronchi, right? So I have seen small children that are doing like this inhaler. You are actually giving the drug to the dead space. You are not allowing the drug to go into the bronchi. So the most important thing is to expel air, take a deep breath, and ask the patient to count to 10. 1, 2, 4, 5. If the patient can breath hold, that is the most important thing. It allows the drug that has gone into the bronchi to sediment in the bronchi. You then breathe out, and it's better and always better not to breathe out through the inhaler, but breathe out of the inhaler, right? So that is the most important things that we have to go through in the inhaler, and then obviously replace the cap, and then gargle the throat as well. So if we have to have 2 puffs, for example, we are taking, we'll say 200 of formoterol budesonide, and you have to take 2 puffs of formoterol budesonide. So you take we'll say we are taking it through the meter dose inhaler and a spacer. You press 1 puff, keep it for 10 seconds, push it out, and then without pressing, I take another breath, at least 3 to 4 breaths from the spacer device. And then again, fixing the spacer again, shaking it again, fixing the device again, and pressing it for the next time and doing the same time. It is not advised to press 2 puffs at the same time, right? Because it is not useful, and you will not deliver the same drugs, the same amount of drugs. right? So this is basically the pressurized metered dose inhaler. So when we look at the pressurized metered dose inhaler specifically, we have this canister, and there is a propellant and the formulation of drug that is there, and that is why you have to mix it. Where there is a drug as well as the propellant. So unless you mix it properly, the drug and the propellant might not mix in a homogeneous way. So before each day, it is very important to mix it at least, we say 1 minute, but at least for about 30 seconds just to mix it. It is very important. And when you're using the metered dose inhaler for the first time, I think you can remember when you use a perfume for the first time, a spray, you had to spray 1 or 2 or 3 times before a good spray come out, isn't it? Like that, we have to prime it before we use the first spray, first use. So usually what we call it primer, you shake it up and then you press once, twice or thrice until you get a very nice fume coming out of the inhaler without any obstruction. And you don't have to do it always, because some patients do it every day. Then you are wasting a dose of your medication, and the drug that was supposed to be for 60 days will be ending up in 30 days. But at least if you have kept the inhaler for about 5 or 6 days or more, obviously we might have to prime it again. But the most important thing is, when you get an inhaler for the first time, we have to advise the patient to prime it before using. Shake it at the first time, prime it before use, but not before every use. But after that, you have to only shake it and use it. And then it will be very effective for our patient. These simple things probably matter, because I have patients coming to me saying that the inhaler went off very quickly, to say that they have been using this. Some people have, shown, some demonstrators have shown that each and every puff, you have to press it and see to whether the drug is coming, but it is not very advisable, right? So this is what we say. If it is a brand new one, shake the inhaler for the 10 to 15 seconds and then prime the inhaler as well, right? So if you have specific questions, I will answer it during the question time. So this is basically what we see, what we do. And this is using a spacer as well. Right. So what is the use of spacer? Some people have a question, because why can't we use it without a spacer? So when we have a spacer, we know that when you have an emitter dose inhaler, there is a rapid flow coming out. And some people might find it very difficult to coordinate this. So, but when you are having a spacer, what will happen is the flow that is coming in will slightly, have a little bit of a delay. And that delay is very important for patients to have, even in a young patient, sometimes pressing the inhaler and taking the inhaler at the same time will be very cumbersome. And but having a spacer will prevent that, will help us to have that coordination better. And at the same time, it will increase the drug deposition, hence reduce the drug waste and have increased efficacy in the long run as well. So what I usually do is, if I'm usually prescribing a meter dose inhaler, I usually prescribe a spacer for that patient for that matter. Right? Right. So, yeah. So what I have told is that, there are enough videos that are circulating about the inhaler techniques, but I want to highlight the most important ones, and I will definitely be sharing this presentation. Because of the time, I don't want to look at all the videos at the same time, but hopefully you will be able to see them later. So when we look at the meter dose inhaler and the dry powder inhalers, which are at the moment used very frequently and commonly in the Sri Lankan setting, when we look at the meter dose inhaler, as I described previously, it is a propellant-driven aerosol system, and the dry powder inhaler is basically the flow is accentuated by the breath of that person. So we need to have a very good flow, at least 30 to 60 liters per minute, to get the drug inside your throat, right? But the most important thing is that, in the meter dose inhaler, we can reduce the deposition of the oropharynx if we use a spacer, and it increases the efficacy as well. But on the dry powder side, what happens is sometimes, obviously, a patient's breath effort will define whether this patient is getting an appropriate amount of drug into the lung or not. Right? So those are the things that we have to commonly think. Right? When you're looking at a dry powder inhaler, which I think in the right side we have a commonest one. So what are the things that we have to tell this patient, specifically some practical problems? Obviously, the steps will not be different. So usually you have to look for debris and whether it is clean. You have to turn it around and put one capsule in an appropriate way. Some it is horizontal, some it is vertical. And the other one is you close the inhaler and then you have to puncture the capsule. Now, when you puncture the capsule, the most important thing is these needles should puncture the capsule. So sometimes these needles are blunt. So what I usually advise for the patient is that at least every 6 months, change the inhaler device so that the needles will be pierced in the drug. Sometimes it might not be very effectively pierced. And the other thing is, some people, when they press for puncture, they hold the pressing and then they inhale. So what happens is when that happens, the drug will not come properly to the throat, to the lungs. So usually we have to ask them to press it once, release, and then inhale it as fast as possible as the patient can. And usually they should hear a rattle sound coming from the inhaler. And we have to repeat the steps about 2 or 3 times. So basically check for hygiene of the inhaler, see whether the pricking, the what you call this, the needle is working properly, and then load a new capsule. And sometimes the capsule might be soggy if it is kept out. So if it is soggy, it will not work. So it should be in the blister pack ideally. Some people take it out and keep, so sometimes it might be soggy a little bit. But then after that, you close it, press once, release, and then take a exhale and take a very deep breath rapidly and fast. And then you hold the breath like other inhalers, and then you can put it out, and you can repeat it about 1 or 2 times until you feel that the drug has completely come to the chest, and you can open it up and see the capsule to see whether the drug has completely been put out. Right? Okay. So now, in a dry powder inhaler, I think the mechanism is important to understand. There is actually a mesh in a dry powder inhaler. Don't ask the patient, and the mesh should be very patent. It should not be blocked, because the intention of the mesh is to break up the drug and remove unnecessary particles like capsule particles coming to the mouth and depositing in the lung. Right? Okay. Right. So a word about the multi-dose dry powder inhaler. I think the best thing that we can introduce in Sri Lanka is these devices if we can afford, actually. So this is very simple device. If the patient can be given it at an affordable rate, this would be a very simple device. And I know that there is a lecture on the environmental impact of inhalers. And unlike in metered dose inhalers, there will be less environmental impact as well as less environmental impact than the dry powder inhaler associated with the capsules which are non-degenerable, as well as the blister cap which is available there. So here there is a preloaded inhaler, what we call a turbohaler. That's one example. And then you just turn it to the right, turn it to the left. It is loaded. You just inhale, and then as fast as you could, similar to the dry powder inhaler, and then exhale, and then again inhale again to the same way. Right. So when we select an inhaler, even though we know the correct technique of a inhaler, as we previously alluded, one of the most important thing is to look for the inspiratory flow capacity and the capability of the patient. So one of the most important thing that if we can do is to ask the patient in front of you to take a deep breath in, to see whether he can get that breath in, and you can actually see whether the patient can do that. right? And in a certain group of patients, we can look for hand-lung coordination. There are patients with rheumatoid arthritis, with deformed, hands, and sometimes Parkinson's disease, which are tremor. Sometimes they might find it very difficult for a coordination, but unfortunately, some of them will not be able to take the dry powder inhaler as well. So then we have to take the help of a bystander or a helper. And the other thing is some people will prefer the device depending on the device as well. So specifically, a young patient who is working in a bank, an executive might not like the meter dose inhaler with a spacer, and he will find it too cumbersome to put the drug every time and inhale it in front of others. But he will be very likely to use a turbohaler or something like a pre-filled inhaler rather than something else. So patient should be able to decide for himself. And the most important thing in our part of the world is the most important thing is whether the patient can afford the treatment. So sometimes in the government sector, we don't have the appropriate inhalers as well as the devices. So sometimes we might have to interchange, and our family and the general practitioners as well as family physician colleagues are finding it difficult. But one of the most important thing is whether this patient can afford the inhaler as well. And if possible, now as we know in the GINA guidelines are coming out, as well as it can be used in our setup as well, and we have calculated the amount that had to be spent for formoterol budesonide combination plus beclomethasone and salbutamol inhaler combination as a metered dose inhaler as well as dry powder inhaler. So for the country as well as the people, it will be more efficacious, as well as it will be very convenient if we can use a single type of inhaler as the reliever as well as the controller, and we can discuss it in the discussion. So the most important thing is to demonstrate, emphasize the critical techniques, and explain the patient why we do each step. We'll look at the common errors and reinforce device specific principles and understanding. And the other important thing is we have to reassess regularly because this is a complicated device. We are giving it for the first time. There will be many apprehensions of the patient. They will not want to use it. So we have to always check this patient is taking the device properly. And I usually advise the patient to bring the drug with him and the devices with him every time he comes to the clinic or even to the private sector. So sometimes I usually tell, okay, I will not see you today. Come on the next day. I will see you with the device. So then the patients will bring the device in so that we can actually practically see how the patient takes the inhaler. At least you should have someone else to check it for you. If you are too busy, then they will be correcting it and they will be looking at the correct techniques and they will be able to correct and help the patient properly, right? So let me finish this topic by again highlighting common errors in the inhaler use, which are common in the Sri Lankan setting. So the commonest one for the common things, for the two things are poor oral or device hygiene. And we have seen devices, you have seen probably spaces with so completely white out. We have probably seen dry powder inhalers with multiple, even with beetle going inside these devices. So poor oral hygiene as well as device hygiene and blocked mouthpieces are not uncommon unless you check it in a proper way. Sometimes the valve is broken in a meter dose inhaler spacer, and if you don't correct it, the patient will not get the correct doses. And the second thing is the incorrect posture of a patient. If you don't use the correct posture, keep the neck like this, the drug will not be delivered and it will be deposited in the throat. Failure to exhale properly before taking an inhaler is a very important one, common to both ones. And then lips not being tight so that there will be air coming in outside the lung, outside the mouth, so that you will not be able to properly create that necessary pressure, as well as not properly breathe in the volume of the inhaler properly, right? And then rapid exhalation after the inhale, you have to slowly exhale, allowing the drug to deposit. And Again, poor storage, because most of our people don't have proper storage techniques. So some of these drugs are stored in various areas, especially when they don't have a place to keep these drugs. And sometimes they are, as I told previously, they are dampened, they are damaged, and so the drug is not very useful. But specific for in the meter dose inhalers is the not priming the drug, like not pressing 1 or 2 times before taking the drug, and not shaking the device before. And in the dry powder inhaler, capsule is not being activated and missing the piercing. And then in the PVMDI, incorrect breathing technique, poor hand breath coordination, and in the dry powder inhaler, insufficient respiratory flow are the main issues that we are taking. So when we look at these again, these 3 or 4 things again, right? I think when we smile, when we look at this patient, probably we are at fault as well. So hopefully at the primary care setting, as well as in the family care setting, and as Dr. Shweta nicely pointed out, in rural areas, we can make a difference. And I'm being a pulmonologist, I will never, object using what you call a peak expiratory flow meter in diagnosing asthma. We have to learn what is the ideal setup that is used in the ideal setup, but at the same time we should be able to, as professionals, to change according to the situation. So if we actually use a right inhaler and a proper technique, obviously our patients will have a better outcome, so that an inhaler will not be a foreign device that intrigues the patient, but it will be a friendly device, affordable device that the patient will be happy to use, and most likely the patient will have better outcomes. Thank you very much.
Thank you, Dr. Niranjan Disanaka, sir, for that highly practical and clinically useful session. Finally, we move to climate smart asthma care for family practice. We have with us Dr. Sankar Andan Kumar, Chair of the Wonka Working Party on Planetary Health, and experienced family physician with a strong focus on climate and health. Dr. Sankar, over to you.
Thank you, Manoj. Let me just give a second. I hope that you can see can you see the slides?
Not yet.
Not yet?
No.
Now we can see.
Lovely. Okay, so good evening, dear colleagues. Today, I'll take a slightly different lens, how climate change is already shaping asthma and what that means for everyday family practice. This is actually a practical session. I mean, this is about practical changes that we can do and start tomorrow in our clinics, and not anything hi-fi. Okay. Okay, this is the overview of the talk. We have only 15-20 minutes, so I would quickly go through all these things. Before everything, I want to discuss with you 2 major concepts. One is the human enhanced greenhouse effect. As you know, some solar radiation on the left of this picture, just as the left side of this picture, some solar radiation is absorbed by the Earth's surface and warms it, right? And some radiation is reflected by Earth and atmosphere. So this is the natural greenhouse effect. And what is human enhanced greenhouse effect? The greenhouse gases, especially in excess, This is carbon dioxide, methane, nitrous oxide, and fluorocarbons. They trap the reflected radiation and re-emit in all directions, like this, on the right side, right? This causes increased temperature in Earth's surface and also atmosphere. So this is leading to global warming and climate change. So this is one of the major concepts that we have to understand about climate change, how greenhouse gases increase the human enhanced greenhouse effect and lead to climate change. The second concept is about carbon footprint. What is carbon footprint? It's a very simple concept. It is the total amount of greenhouse gases, including carbon dioxide and methane, in addition to nitrous oxides and fluorocarbons, etc. So it's a total amount of greenhouse gases that are generated by our actions, which means, rightly you are thinking, every action has a carbon footprint. So it's not a sin to have a carbon footprint, but the importance is we cannot avoid carbon footprints, but we can reduce it. So that's all. So carbon footprint is the total amount of greenhouse gases that generated by each and every our action. So each and every action has a carbon footprint. Okay. Having said that, why the climate smart asthma care does matter? Colleagues, you know that asthma is one of the most environmental sensitive diseases because we always take a social history, which is very important, especially in asthma care, right? So we are asking about the environment in a different way, but we ask mainly about the household, the pets, and the occupation. But then, same way, environment has a lot to do. On the other hand, climate change is not future. I mean, now at this moment, it's affecting us. The pollution levels, allergen exposure, extreme weather events. So all this stuff is happening, especially in South Asia. Why? The South Asia is home to quarter of world population, 25% of world population, right? So high exposure, dense population, and limited adaptive capacity due to our low and middle income setup. This makes our patients particularly vulnerable to climate change. So we are already seeing climate change in our clinics. So climate smart asthma care is very, very important. And how climate change affects asthma? Only there are a few simple things. For an example, when the global temperature goes up, our temperature goes up. We all experience this in each of our countries. When temperature goes up, there's a production of more ozone. And this leads to airway inflammation. And climate change has effects for extreme weather conditions like flooding, hurricanes. So flooding and this stuff will lead to damp homes and mold. So again, another reason for asthma. Then we just think about dust and wildfires in some of our region. So they lead to acute asthma exacerbations. And then not each and every country, but in some of our countries, there are seasonal variations and longer pollen seasons. So this will increase asthma symptoms, prolonged asthma symptoms due to pollen exposure. It is mainly, the pollen exposure is mainly important in European or Western countries, but also in some of our countries where the milder climates are there, they have very, very distinct seasons. So they have this problem as well. So these are the reasons why your stable patient suddenly become uncontrolled. So you are managing a stable asthma patient, but suddenly that patient become uncontrolled. But then you wonder why this is, but you wouldn't find a reason. But of course, here's the reason: the environmental change, the climate change, and its effects. So what is climate smart care? It's not about adding further burden to your already busy clinics. It's about reframing the care you already produce. So there are mainly three pillars. One is good clinical care. Then being aware about the environmental drivers or the being environmentally conscious. And third thing is prevention and sustainability. So this is not environmental activism, right? This is all about better clinical care for our patients. We can start caring our patients with regard to the climate change at the first encounter from the history taking. So there's no need to go through long checklist. You can just ask one or two extra questions. For an example, like, do you have symptoms that are worsened with weather or seasons? Or do you have any exposure to smoke, dust, or damp housing? What do you use for your cooking? Because indoor air pollution is also important factor. And also about the occupation where whether they are exposed to dust or particulate matter that are around us. So whether they are a particular vulnerability. So what I suggest is a 30-second environmental history taking that is added to our history taking. It will take only few seconds, 30 seconds maximum probably. And that can completely change our management in these different times. And think about the vulnerable patients, especially this type of patients when they come to your clinic, like children, elderly people, pregnant women, and people from low income setup or from rural population where they have poor housing conditions. We heard that some of speakers were talking about the housing conditions, for example, the floor, the cement floor, whether they are sleeping on the floor or not. These things are also important. So especially these type of vulnerable patients come to your clinics. Take a full history about the environment as well. So we all understand that asthma severity is not just biological, as we were always thinking. It is social and also environmental. And just as Dr. Maitri was talking to family practitioners, peak flow monitoring is still important. And also symptom scores are still useful. So when you are assessing your patient after taking the history and the examination, think about assessing in these lines as well. And even though you go through this peak flow meter and symptom scores, still there will be some numbers. So numbers without context can mislead. So always think about environment. So environment will explain the variability. And we know inhalers are gold standard for managing asthma. But now we are thinking about sustainable inhaler choices. So an emerging aspect of care is also environmental impact of our treatment to our management. So where we should go, whether we should select an MDI or a DPI. Okay, I'll give you some tips. The carbon footprint of the MDIs are very much more than the DPIs, and this majorly because of the propellant gas that they have in their canister. And these were or are the propellant gases used in the MDIs. CFCs are not anymore used after the Montreal Protocol in 1987. We stopped using CFCs after 1995, but still we use HFAs. those are hydrofluoroalkanes, or you can simply say hydrofluorocarbons. So HFA 227 and HFA 134 are still used, and out of these, HFA 227 is more harmful. You can see that something is there under that, which is most harmful things, GWP. GWP means global warming potential. This is measured in terms of carbon dioxide kilograms. So just think that it has more impact to the environment because it has more damage causing effect. The good thing is we went for another amendment of the Montreal Protocol in 2016, which is known as Kigali Agreement. And this was developed to phase out all these hydrofluorocarbons as well, but it has a long time, like until 2050, sorry. So they start in 2020 and until 2050, they can phase out HFCs. So HFCs are used not only in inhalers, but they are also used in refrigerators and air conditioners. So even though the governments of 170 countries, as I can remember, have signed this agreement, they will always prioritize things like refrigerators and air conditioners. So I think we have a lot to do because 2050 is long. We have long time to 2050, right? So we cannot just stop and just watch, okay, that everything will be better in 2050. So we have to act from our side. One good news is that MDIs with a lower global warming potential are also being tried or researched, like HFC 152A and HF4. And even there are some new things called soft mist inhalers. They will also be available probably in next few years or so. But from our side, we have to reduce the impact that MDIs do to the environment because of its higher GWP. This is a visual diagram for you to understand the harmfulness of MDIs. If you can see these bigger circles, they are representing MDIs, combination of MDIs, salbutamol, and steroid. But if you see the right side, smaller circles, they are DPIs. So you can see that all the DPIs would just emit about 1 kilogram of carbon dioxide, while MDIs, even the lowest harmful MDI, would emit 10 to 25 kilograms of carbon dioxide. If we give another understandable example, using an MDI is similar to driving a small petrol car for 280 kilograms, while using a DPI would be driving the same car only 6.5 kilograms. So roughly, MDIs are 20 times harmful to the nature, the environment than DPIs. So colleagues, the bottom line is MDIs have a higher carbon footprint because of their propellant gases, and DPIs do not. They also have a carbon footprint, of course, but it is not harmful as MDIs. But most important thing as family doctors is whether it is suitable clinically. So that comes first. So please provide personalized care to your patients, but also keep the environment in your mind. And what about the efficacy? I think Dr. Niranjan gave a nice slide which made my life easier because the particle size of both MDIs and DPIs are in between 1 to 5 microns. So which means both of them, both MDIs and DPIs are suitable and their efficacy would be more or less the same. So we have a lot of evidence for MDIs and DPIs similar efficacy, even though many of us, including me, were trained to believe MDIs are superior. And as you can see, the evidence say, these are high quality evidence, includes Cochrane reviews. So they show no significant difference in outcome when used correctly. Both MDIs are and DPIs are more or less efficient. The lung functions would be similar and the symptom control would be similar. If you are interested, please go through the research and you can read along there. So the core message is the issue is not the device. The issue is technique and the patient match. So if you can use a DPI in a patient, always you can use it without hesitation because the efficacy is more or less the same. And also, short-acting beta agonist overuse will lead to poor control, and the poor control will be more or less leading to more exacerbations. So, which means the better asthma care automatically becomes more sustainable and environmental friendly care. So, as family doctors, patient education is very, very important. So we can educate and advise our patients about avoiding pollution peaks, wearing face masks when they have to go out, especially in a urban environment or when the pollution peaks are there, and to improve the ventilation in their houses, which will improve the indoor air quality, also reducing damp, mold, or dust in their houses, or keeping their houses clean, and also managing pollen exposure in the areas where the pollen exposure is important. So simple advice can prevent these exacerbations more than medication escalation. So that is the most important thing we have to keep in our mind. So what could a family doctor do? So start with the history, integrate environmental history taking into our history taking. And remember that you are not just prescribers. Family doctors are the first contact people. Then they will provide long-term continuity of care and they can influence the communities. So primary care is where climate and health actually meet. So you can do a lot here. And ensure your patients need an inhaler. Now we discuss about underdiagnosis, but also not only underdiagnosis, overdiagnosis is also a problem, especially in asthma and COPD. So overtreatment could be another issue to prescribe an inhaler. So firstly, do a correct diagnosis and ensure that your patient needs an inhaler. Then always consider dry powder inhalers as an option. Usually patients over the age of 6 years with good inhalation effort can usually successfully use DPIs. So always make the DPIs your first choice. But it's your choice. I mean, it's your clinical judgment always. In a case where you have to prescribe an MDI, meter dose inhaler, always prescribe it with a spacer. So before we talk about the hand-lung coordination, so I think that's why a spacer would be important. That will also reduce the undertreatment and prolong use. And educate your patients on inhaler techniques and review them frequently. I think this is very, very important, following up your patients. as Dr. Niranjan was telling, educating your patients on inhaler techniques, show them how to do it, assess them at the first instance, and then follow up them on and off and see whether they are continuing the proper technique. When it comes to the asthma control, adhere to the latest guidelines. We were talking about GINA guidelines, where inhaled corticosteroids and long-acting beta agonists are being used. And try to make the asthma control better. So it will avoid unnecessary emergency room visits, which will also increase hospital admissions. So another thing where we reduce asthma exacerbations, we also reduce hospital admissions in an indirect way. And as I taught, follow up, and not only follow up, step down when control is achieved. Sometimes people use their inhalers forever. So it's our duty to assess them frequently and reduce, tail off when the control is achieved. So regular follow-up would be the most important thing here. And in addition to that, as responsible family doctors or responsible physicians, discuss about climate change and carbon footprint with your patients and your community. There's no need to make your patients feel guilt or shame if they are using an MDI and it is the best for them, right? It's the most appropriate thing. But discuss about other things. Discuss about the environment, the climate change, and what they can do, not related to this probably, that in that case, even about the planetary health and climate change related carbon footprint reduction that they can do. And then also advise on safe disposal of inhalers. Make sure that any inhalers you dispose of go into medicine waste. I mean, when incinerated, the HFA, HFCs or HFA degrade into far less potent greenhouse gases. So it's very important to dispose them safely, and they are going to the medicines waste and they are being properly incinerated. And also, colleagues, advocate for having DPIs as the first line choice in medical guidelines, policies, and health system discussions in your countries. That is also part of our responsibility. So, colleagues, the take-home messages are climate change is already affecting asthma, and we are seeing climate change in our clinics. Expand history taking and assessment to the environment, adding 30 more seconds to your history taking. And DPIs are similarly effective as MDIs if they are used correctly. So choose rationally and sustainably and give your patients personalized care while thinking about the environment as well. So we must treat not only the lungs, but the environment that shapes those lungs. So these are the references. And thank you very much.
Thank you, Dr. Sankar, for that important and forward-looking perspective. We will now move on to the Q&A session. And we have got several questions in the chat. Most of them are regarding inhaler technique, I think. The first one is, how many times a patient has to inhale after taking one puff of inhaler through volumetric spacer? Niranjan sir?
Yeah, thank you very much. I think I went through some of these questions, and they are really interesting and practical questions that they have raised, and I think we should answer them. So that's why I stayed at the until the end. So one thing is how many inhale times for one puff in the volumetric spacer? Now, Now, some people think that in the volumetric spacer, when you push push the MDI, and the drug will be there in the spacer for some time, so that you have to take it until it is finished. But truly speaking, at by about 2 or 3 inhales, the complete drug volume will be delivered to the lung. So sometimes we tell the patient to take it for about 5 times. We ask the patient to shake the inhaler, get the spacer inside, fix the inhaler MDI to the spacer, tight, press, push out your lungs, and then keep your mouth tight, and then press, and then take a slow breath, and then push it out. And at the same time, ask them to take another breath, slow breath, keep it for 10 seconds, push it out. So when we do it for about 3 to 5 times, it will be more than enough. And even 1 to 2 times would be enough. But, in the Sri Lankan context, most of the people, just if they take, we ask to take it once, or, twice or thrice. Sometimes they might not even take once or twice. So I usually ask them to take about 5 times. So, but at least, truly 1 or 2 inhales after the device would be more than enough, actually. So that I think I have answered. And there was another question. Basically, if someone is having to take 2 puffs, for example, someone is having to take 2 puffs of tiotropium mitral inhaler. So usually the tiotropium inhaler will have 9 micrograms, especially when we are using it for COPD. The dose is 18 micrograms. So what we usually do is, even in salbutamol also, sometimes you might have to use about 2 or 3 times the inhaler to get the appropriate amount of drugs coming in, especially when there's an acute attack. So again, you have to repeat the same procedure again. Rather than fixing the MDI, pressing it twice, thrice, or 4 times, and taking the breath in, we have to repeat the process each time like this. So if we say, for example, we have to take 3 puffs, right, of that particular MDI. So you again go through the similar thing. You shake it, put it in, put the breath out, push, breathe in, keep it in, and then push it out. Again, breathe in, keep it in, push it out, and 3 times. And then you stay for about 30 seconds, right? Remove the MDI from the spacer. Again, mix it for about 10 to 15 seconds. After about 30 seconds, again, you put the inhaler back, and then do the same thing again. We should never press the inhaler twice at the same time. So I think it is clear now. Hopefully, it is clear for the doctor who asked that question. Right? Is the turbohaler currently available in Sri Lanka? Yes. I don't want to go into brands, but from one company, turbohaler is available for the formoterol budesonide combination. I will not be able to tell you the brand name because it is not ethical. And at the same time, budesonide is also available as a turbohaler inhaler. So in certain groups of people, it is rather expensive than when you use a dry powder with a device, as well as MDI with a device. So sometimes I usually prescribe it to patients who, sometimes when they can afford, when they look at convenience, when they can easily take it in their handbag, without taking this bulky inhaler, and something like that. And if the patient preference matters as well as the affordability, then I usually use that in certain settings. Do we need to wash the dry powder inhaler? We can wash the dry powder inhaler, not every day and every time, but if it is getting a little bit, having the residue in there, yes, you can, some dry powder inhalers you can actually remove, and then you can wash it. But until it is completely dry, you should not put a capsule in. So it should be allowed to dry allowed to dry not in the sun, but in a good area where there is a good ventilation, and until it is completely dried out. And you, especially if there is, sometimes the water will be there in the mesh. So the water usually, when you have something like this, like a square, water usually will be there in the mesh. So you have to remove the water and then allow it to dry as much as possible. So that is the answer. Can we use space as an alternative to nebulizer? Absolutely, we can. And it has shown that it is almost efficacious as a nebulizer in acute asthma attacks in certain instances. But we have to use the correct technique. And the patient, when a patient who is agitated and who is in severe breathlessness might not be able to press the inhaler by himself. So, and ideally, sometimes, so if you can help him take the inhaler until we go to a hospital where the nebulizer is available, it is usually, it's an accepted method. But again, if you're using 4 puffs of salbutamol, press 1 puff, ask the patient to breathe in, in the normal way that the patient has been breathing. Sometimes you might not be able to hold the breath as we should like, but even then try to hold the breath as much as possible for that patient, and then keep for about 30 seconds and then give the next puff and then repeat like that. The important thing is when you have when you have asthma or a COPD exacerbation, the patient starts to panic, and they are anxious, and they will not be in a mental state to take the inhaler in a proper way. So, and sometimes they might breathe through the mouth, they will not be able to seal the inhaler. The mouth seal will be not be very effective because they will be trying to get air as much as possible. Hence, the efficacy of when you call this MDI, when in an acute state, might not be that much not due to the drug delivery system, but because the way that the patient is taking. Hence, if a patient is having severe attacks, ideally the patient should be nebulized. But until then, if it is not available, the MDI with a spacer is an alternative that we can use, provided that the patient is using it in a proper way, at least to a certain extent. Right. And the next thing is how many puffs of DPI or MDI salbutamol can be used maximum during an acute asthma episode? It is not the how many puffs. You have to look at whether this patient is whether he's improving or not. So, what we usually do is, give 4 puffs and wait for 1 minute again and see whether the patient is improving, and again repeat that. And if the patient is not improving, ideally we have to seek medical opinion and see whether the patient is whether the patient is whether the patient is better or not. But it all depends on the clinical picture of the patient and whether you can reach the hospital very rapidly. Better not to delay. If you think that the patient is having a severe attack of asthma, better not to delay. Maybe when the patient is being transferred, you can give these inhalers, the metered dose inhaler, until we take the patient to at least a primary care center where the patient will be able to be given appropriate care. But if it is a moderate exacerbation, yes, we can look to see whether the patient is improved. But if the patient is not improving by 20 minutes to half an hour, we should definitely look for other treatment options. Okay. Did I answer everything, or do I have any other questions?
That's it.
Yeah, there's another question from Dr. Razika. If a patient has typical symptoms of asthma with atopic dermatitis and food allergy, families of asthma, no rhonchi, can we still say it is asthma? Probably yes, we can. And I think Dr. Sweta has also answered that. Yes, we can, because sometimes rhonchi will not be there. So that is why sometimes even when the rhonchi are not there, peak expiratory flow meter will be helpful to look at the peak expiratory flow rate. And then we might see, even if there might be even though the rhonchi, if you don't hear, the patient might be having a significant obstruction without bronchi. So we might be able to prove it that the patient is having obstruction. As well as in asthma, it should be variable as well. At least 20% variability will be there in the morning and the evening. So if you can prove that, you can actually prove that the patient is having asthma. And I would like to actually, in that moment, congratulate Dr. Shweta for an excellent lecture on asthma in the underprivileged. It was brilliant. I enjoyed it very much, together with our other colleagues as well, who did, we looked at, I have been listening to asthma talks, but the types of talks that you have included in this symposium, including the last lecture, but by Dr. Randani Kumar, was very thought-provoking. And those are aspects that sometimes we usually don't look at. So thank you very much, organizers, for arranging this excellent lecture series and inviting me and giving me the opportunity to talk to you as well. So any other questions that you have seen, or is it okay?
There's one question. I think it's for Dr. Sankar. How to dispose MDIs?
Manoj, as I told before, they should be collected separately, not in the common bags in the general waste. They should be under clinical waste, but ideally they should be incinerated, which means they should be burned in an incinerator where you reduce the propellant gases, the harmfulness by burning them. So that is the only way that I know that there are some companies who collect clinical waste, even in Sri Lanka, in other countries, I'm sure. So these could be probably what we can do is that we can take over these inhalers from our patients. We can collect them for our patients and we can hand over them to clinical waste. I think it would not be a big issue because I mean there wouldn't be hundreds of MDIs or DPIs coming to you at once. It's mainly MDIs is the problem. So it should be incinerated mainly. That would be the ideal way of discarding it.
That's an excellent suggestion, Dr. Sankar. So as we come to the end of the today's session, I would like to sincerely thank all of our speakers for sharing their expertise and time with us. Dr. Sasanka Rajapaksha, Dr. Sweta K, Dr. Maitri Rupasinghe, Dr. Niranjan Disanayaka, and Dr. Sankarandani Kumar. And special thank you to Dr. Vishnu Bina Satish, Regional Chair and Council of the Spice Route South Asia, and Dr. Parami Abhiratna, Secretary of Spice Route Sri Lanka, and the National Committee of Spice Route Sri Lanka, and the College of General Practitioners of Sri Lanka. And finally, thank you all, the participants, for joining us and making this session meaningful. Your CPD certificates will be sent via registered email in 2 weeks. Have a great evening and a happy World Asthma Day. Thank you.